Hello and welcome to our Friday's event tonight at 6 p.m. So it is time to start our live event, another online patient meeting. We are having another topic to discuss, and I hope you had a nice Friday already and you are keen on finding out some more information on our topic. But as always, first of all, let me simply remind everyone that we are here every single day to support you through the waiting. Most of you are not able to still proceed with your treatment. So we definitely want to give you a chance to ask your question to top fertility experts. And well, all those events are always brought to you thanks to our ambassadors and partners. And there are like a few more that you can see today as more partners, more ambassadors have decided to join and support our initiatives. So thank you so much for that. And tonight, there is another topic to discuss, and this time it's miscarriages and embryo implantation failures versus PGT-A. So, and our special guest tonight is Alsu Saifitdinova, PhD, embryologist and molecular biologist from a clinic International Center for Reproductive Medicine, which is located in St. Petersburg in Russia. This is our second expert from International Center for Reproductive Medicine. So I'm very happy to have you with us tonight also. And please let me know that you can hear me. And how are you feeling today?
Yes, I'm here, and thank you very much, Caroline. And I'm fine and ready to start our meeting.
Excellent. Happy to hear this. So, of course, as always, we will start with the introduction from Alsu. Then we will go for those questions that are most common. And then, of course, as always, it will be time for your questions. So, as always, do not miss your chance to ask your questions so that also can help you out a bit as well. And, well, let's begin. Also, ready?
Okay.
Excellent. Happy to hear this. Go ahead.
And I would like to start with introduction of our clinic and myself. And I must say that I represent here International Center for Reproductive Medicine from St. Petersburg. And I must say that we started doing PGT really in early 2000s, and we followed protocols of Yuri Berlitsky. And for me personally, I started doing it from 2007, and at those time we used fluorescent in situ hybridization technique, and now, of course, we are using some new methods for analysis, and of course, we're still using different techniques just to reach the same goal, to analyze the genetics and chromosome balance in embryos. That's maybe just general place of our clinic in this analysis and some of our experience.
Perfect. Thank you so much for that introduction. And so, are you ready to start with the questions already, or?
No, I think that I can a little bit say some words about PGT in general.
Perfect.
Because I
Go ahead.
think that just for beginning, we need to understand that this is some genetic methods which applied for analysis of really early embryos, and this is the earliest genetic analysis and testing that is possible, just because we can analyze the embryo's genome before implantation. So all the methods which could be done before implantation was joined together, and now we call them all pre-implantational genetic testing. So this is in general all methods, and this group of methods contains some different. It could be done for different reasons and for different purposes. And among PGT, we can uh, we can separate different particular methods, and this is PGT-A, which will be the topic of our discussion today, and then PGT-M for this is implantation genetic testing for monogenic disease, and then PGT-SR, which needs to do pre-implantational genetic testing for chromosomal rearrangement carriers. So today we are going to talk about PGT-A, PGT, pre-implantational genetic testing for aneuploidies. Aneuploidies means imbalance in chromosome number. So um, now I think that we can start answering questions. Um,
All right. Excellent. Thank you so much once again. And now let's go with the most common questions. And first one is, so how is PGT-A different from PGS and PGD?
yes, this is really a commonly asked question because for quite a long time, during quite a long time, we divided all the pre-implantational analysis into two groups. PGS means pre-implantational genetic screening, and PGD is pre-implantational genetic diagnostics. And these two groups was based on those methods was that was used maybe about 10 years ago, and sometimes it was some kind of confusion in methods and confusion in the particular goal of using um, this analysis. And after that, when some new approach was involved in implantational genetic analysis, it was even more difficult to understand which particular analysis necessary to do for the particular family. That's why it was really international decision to divide all pre-implantational genetic testing into those three groups that I mentioned before, and among them, those which analyze aneuploidies was separated, and now it completely cover the term PGS. So PGS means PGT-A, but PGT-A sometimes also some have can include some information about um, uh, chromosomal abnormalities if we will think about sex chromosome abnormalities, for example. So PGT-A, it is about the same as it was PGS, that this term was used for some years ago, for quite a long time. And now we mainly can find just PGT-A instead of that. And PGD will go for different types of PGT, which intended to analyze monogenic disease, that is PGT-M, or structural chromosomal rearrangements like PGT-SR. Okay, and we can go to the next question, I think.
Excellent. Thank you so much for answering that very first question. And yes, let's go to the next one. So why does PGT-A increase the likelihood of implantation?
Yes. So it's maybe at the beginning it's not obvious, but unfortunately, the chromosomal abnormalities is one of the feature of human embryos, and it comes from the uh, nature of chromosomal behavior during oogenesis and spermatogenesis. And we should remember that oocyte is quite old cells, so they a little bit usually they a little bit older than a woman that have these oocytes, and at this age they could do some mistakes in chromosome separation and during cell division. And it is really important division which happens with oocyte when it prepare to transfer the genetic information to the next generation. And at this time, it is possible that some chromosomes could be lost, or it is also possible that it could be some gain in chromosomes. And then this oocyte can be fertilized, and we will have new embryos that would have just at the beginning it will be just one cell, but it would have uh, um, old number of chromosomes. So some chromosome could be represented in 3 copies or in 1 copy, or sometimes without some chromosome, or even sometimes it could be 4 copies of the particular chromosome. And in this case, the normal genetic information of development of this embryo wouldn't be realized properly, and it caused some inherited diseases. And mainly it could be it is the most common reason for some defects in the early development, and this embryo wouldn't have any potential for implantation or development in a healthy child. So analyzing chromosomal number at the beginning before implantation, you would find those embryos which will have potential for implantation. So this is one of the most important thing, how to select those embryos which will be which will give rise the healthy child, and which can give normal proper pregnancy. Okay.
Perfect. Thank you once again for explaining this question to us. Next question is right here. How exactly can PGT-A affect the outcome of an IVF cycle?
Okay, as I already said, that first of all, PGT-A can help us to select those embryos which have proper chromosome numbers. And another important thing, that we also can select just one embryo. We don't need to transfer more than one, just in case if someone will be with some mistakes. So we can select those which have the highest potential, and then give the best condition for this embryo for the implantation, because we wouldn't put them together. We wouldn't try to put transfer 2 or 3 embryos, just in case if some of them could be incorrect, and could have some mistakes in chromosome numbers. So in this case, we would give at the very beginning of the process of implantation, we will give the best condition for those embryos which have the best potential for the development. And this is the most important thing, because PGT-A absolutely exclude possibility of miscarriages during first trimester. And actually it has a really simple explanation, just because when it was analyzed, when we're analyzing those embryos that stopped in their development during first trimester, usually they have some chromosomal imbalance. So this saves us some time, and it helps us to find those embryos which have better the best possible potential for development. Then we give them possibility to give pregnancy with singleton, not trying to transfer more than one embryo. And another important thing, that this helps us to exclude multiple pregnancy. So after that, the outcome of that IVF cycle will definitely better than we just try to transfer unanalyzed embryos. Okay.
Excellent. Thank you so much once again for that explanation. Next question is right here. So, is it possible that manipulation with embryos for PGT-A will reduce its viability?
Yes. And sometimes people really worry about the viability of embryos after the manipulation for PGT-A. Of course, we need to take some cells from the embryo, and it was shown that at the very beginning, during first cleavages, the human embryos divide into 8 cells, and each cell from this embryo have equal potential. So each of these 8 cells can develop into uh, normal organism without any mistakes and so on. And it was really important finding which helps us to develop PGT-A at the beginning. And then we developed new technique which is a little bit even less hurting, because we now we are analyzing just some cells from blastocyst stage, and at this stage the embryo has about 100 and maybe a little bit more cells, and we we are bio- we are making biopsy, and we just taking not more than 5 cells or about 5 cells for this analysis, and all of these cells are not from inner cell mass, so they are not those cells that should give rise to the embryo. This is cells that surround embryo and that helps it to for implantation, but it is about 100 of such cells which should help this embryo, and we just pick up just really really small number of cells for analysis. And of course it is important that manipulation should be done strictly following the protocol, and all of the people who involved in this process should be really experienced. So I think that it is important to choose clinic with a long experience, with a highly qualified embryologist who can do it properly. And in this case, there wouldn't be any consequences for viability of the embryo.
And once again, thank you so much for clarification to this question as well. Next question. If the likelihood of unemployment depends on a female age, is PGT-A appropriate for a young woman or donor oocyte cycles?
Okay. First of all, I must to say that even young women already have not really young oocytes. So even 20 years old woman has oocytes of 20 years old. So they are not just freshly divided and young cells. So if we will compare with other cells in our organism, for example, blood cells or some other cells, skin cells, they are really young. They renovate it every time and every day, and some of them not older than 10 days. And if you will think about oocytes, they are really old cells, and even at the age of 20, uh, when we started analyzing these embryos, we can see that about 30% of oocytes would be aneuploid, and it was really puzzling when it was found, because of course we know that after 45 35 years old, we could see that the number of aneuploid cells increase, but even if we're analyzing oocytes from young womb and from donor oocytes, we can find that about 30% of oocytes would be aneuploid. And of course, it would depend on the particular situation. Of course, uh, there will be some differences in the number of aneuploid cells, but unfortunately, we wouldn't say that if this woman is young, she wouldn't have any aneuploid embryos. It will be about 30% of them which will be aneuploid.
And once again, thank you so much for explaining this question as well. Next one is here. Is there a need to do PGT-A if the karyotypes of the both partners are without pathology?
Okay, as I already said, that our karyotype is really important thing. It comes from the chromosome number for the parents, for those women and men which want to have this baby. And of course, if they don't have any rearrangement, they have a low risk for some kind of mistakes. But as I said, that the most common mistake that occur at this period of time is chromosomal number mistakes, which came from the which based on the age of the oocyte. So even for those people who are not have any kind of pathology in karyotype during oocyte maturation and this special cleavage, meiotic cleavage, which produce oocyte, the mistakes occurs, and they occurs with high frequency for those who are a little bit old. So it depends on the age, but not on the character.
Excellent. Sorry. Thank you so much for that. And now it will be our last question when it comes to those most common ones, and we will move on to your questions. There are some questions ready for you. So let's get to them. The last one. If PGT-A does not reveal any pathology, will it 100% exclude the risk of miscarriage?
This is really important question and um, really commonly asked. So I must say that when we are doing PGT-A, unfortunately, we're analyzing only 5 cells. So we are not able to analyze carefully the genome of the embryo, uh, the nucleotides, the nucleotides by nucleotides, all the letters in the genetic code. So we just analyze the chromosome number. So we don't know a lot of information about this uh, embryo. So we just can't say that it will have all chromosomes. But unfortunately, apart from the chromosomal diseases and chromosomal mistakes, there could be some monogenic diseases, and they would have impact on the development as well. And again, we also will have all the factors which influence during the pregnancy, and we will have all the factors which will have impact on the realization of genetic program. And that's why even if you have perfect PGT-A analysis, you wouldn't say that you will have 100% of insurance that there wouldn't be any genetic mistakes or genetic diseases or some kind of risk of miscarriages due to different other reasons. So we just try to select the best, and we just try to do the best. But unfortunately, as usual in all natural things, we can't say that we will 100% exclude any risk. Yes.
Excellent. Thank you so much once again for answering all those questions, those most common ones. And now we will go for our patients' questions. So, also, are you ready for the patients' questions?
Yes. Yes.
Excellent. There are a few right here. So, let me show you the very first question. What is the usual cost in PGT-24 testing for each embryo, or do you offer packages? Is the testing done in your clinic or sent externally?
Actually, I think that I can't say the particular cost for the for this test just because the situation is changed. You can check it on the website of the clinic, and each clinic have as an open information, and it just depends on the particular uh, price situation, and we are doing it in our clinic. We are doing. It for each embryo, and for PGT using PGT-A for 24 chromosomes, we can't offer any package just because each embryo have the lowest price that for analysis that is possible. Because I must say that now this analysis could be done everywhere, so it's not a kind of some type of analysis where the price um, is really higher than the cost of the materials, and that's why it's just the lowest that possible, just because of the situation with PGT now. It's not like it was maybe 10 years ago when just some clinics can do it. And if you will say about uh, tests which can be done here in our clinic or somewhere externally, of course, it would depend on the protocol. And actually, I must say that some part of the analysis could be done in another clinic. But if you are having embryos here, the biopsy would be done here, and then if you would send it really far away, you could remember that during this transportation you would have just 5 cells in one tube. So something happened with this tube. It could be melted, and well, this freezing, melting, freezing, thawing process could destroy could damage the DNA in the tube. So if you need to send, if you want to send for analysis these cells for analysis somewhere far away, you should remember that you could have a result that the analysis wasn't possible. Just do a rare biopsy again, something like this. So
All right. Excellent. Thank you so much for, for your question as well as your answer to this. Okay. There is another question here. Is there any chance to do this analysis quickly, shorter than in a month?
uh, unfortunately, now it's quite usual that you have to do cry cycle, so you need to freeze your embryo, and it depends on the particular type of analysis. So if we are talking about PGT-A using NGC, so it's next generation sequencing, and or if you are going to do some array CGH analysis, you would obtain the cells just at day 5 or sometimes at day 6. So at that time, you have just some hours for transfer of this embryo to to the mother. But this some hours is not enough for full analysis of all chromosomes. But at those time when we analyzed them using fluorescence in situ hybridization technique, we usually did it in a fresh cycle. But there are another restriction. If we are doing it using fluorescent in situ hybridization technique, we don't have any possibility to do in these 2 days, because at those time it was a biopsy at day 3, and we don't have possibility to do all chromosomes just because it is just one cell, one nucleus, and you need to check all chromosomes. So I must say that in our clinic we have maybe the highest number in the world where we could analyze in fresh cycle up to 12 chromosomes. So a half of those that's possible to analyze using new techniques. But unfortunately, the price of this better quality of analysis is time. And I hope that maybe developing new methods which could be a little bit faster and do this analysis faster gives us possibility to obtain results in some hours. If it comes in clinic, so immediately we will start doing it in a fresh cycle because sometimes it is necessary just to do it in fresh cycle. But now we have just this possibility, and I must say that there are some advantages of this because from gynecological side, uh, you can prepare a little bit better for this transfer. And now, when we have this situation with COVID-19, it is also a little bit better if you could freeze your embryo and then wait before a situation will be a little bit better with virus. I mean, with virus environment, maybe wait a little bit before vaccine appear, and then uh, come and have these embryos for implantation.
And again, once again, thank you so much for your question and, of course, your answer to that as well. Next question is up right here as well. Why do you have to freeze the embryo after testing the fifth day embryo for PGT? I have been told that I would have to revisit the clinic at a later date for the implantation. I would prefer to do everything in one trip.
And again, the question about the same topic as previous. And as I already said, that it's just time that we need to spend on the analysis. So we need to process them to do this amplification, DNA amplification, and then DNA sequencing. So it takes time, and it takes a little bit more time that we could wait before transfer. So if we would wait before the end of the analysis, our embryo will grow out, and then it wouldn't be it wouldn't have um, potential for implantation. So of course
Of
we could
course.
try to do it as fast as possible, day 8, but what we would do with the embryo at day 8.
Yes, of course. Thank you for clarification. It definitely would be easier if we could simply do it in one trip, but it's still not possible. Yeah, simple as
Unfortunately,
that.
just because of the technology.
Of course. Perhaps in the future. Yes.
Yes, we hope.
Exactly. Thank you so much. Excellent. Thank you for another question as well. And here is the question. In absence of clear reasons, why do embryos, excellent A, fail to implant, and in the absence of reason related to woman's health or her womb's quality, health that could have caused the failure, would it be advisable to do PGT, PGD, or karyotyping of the couple?
First of all, I must say that I would advise all couple which came for IVF to do karyotype, because sometimes we unexpectedly can find some information about balanced chromosomal rearrangement in 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 a couple. Some people have this chromosomal rearrangement. They carry them and they don't know it before they came in IVF cycles, and it is really quite often, and really one of the important reason of uh, failure in pregnancy, having chromosomal rearrangement. So I would advise to have karyotype in case if you have any problem with having pregnancy. Just to exclude that there could be some mistakes. And why it is so important? Because if you would have some mistakes in chromosomal organization, uh, using IVF, you could have embryo which will look as perfect just because during the first cleavages division, this cells would use the potential of their mother cells, and they would divide properly, and they would organize in proper blastocysts, and they would look perfect, and they would have perfect potential for implantation. And then if there was some mistakes in chromosomal rearrangement in their parents, they could have some gain or some loss of some small part of the genome. So in this kind of defects, chromosomal defects, they would have developed uh, developed babies with some diseases, and it is even worse than not having children. And that's why karyotyping is really important, and you should start with it if you just want to enter the IVF cycle. And again, uh, another thing that some people have some a little bit higher rate of chromosomal mistakes in embryos, and again it depends on the genetics, and unfortunately it is really hard to find it using usual methods, because sometimes it's just some genes that help cells to separate chromosome properly, or some other types of or cellular proteins which works usually normally in our bodies, in our cells. But if we are talking about oocytes, for example, which, as I said, quite old cell, in this case these mistakes came a little bit begin to be a little bit more important. So for normal cells which divide really fast, and it's just mitotic division, some insufficiency in some proteins could be not so important, so it doesn't hurt them really critically. But for oocytes, it because of this aging, it came to the a little bit bigger problem, a hard problem. So in those people, the rate of the embryos with chromosomal mistakes could be a little bit higher. So if you already have some experience in uh, miscarriages, and it is really important not just have experience in miscarriage. You need to try to have all the information about this pregnancy to karyotyping this material, these embryos, just to understand the reason. If it is repeated chromosomal rearrangement mistakes, even if it wouldn't be the same chromosome, it could be different chromosome missed or gained, uh, it can be a kind of prediction that it is better to do PGT to select the euploid oocyte before transfer.
Excellent. Thank you so much for clarification. That is definitely complicated, but of course, thank you so much for those details you have provided. There are like 2 questions left, so we will be slowly finishing. But of course, I encourage anyone, if you have any questions left, go ahead and type those in so that also can help you out as well. And next question is here. What is the percentage of euploid embryo for 33-year-old?
This is really good age for women, because at this age, at the age about 30, the percentage of euploid embryos is is highest. It's really interesting, but for younger women, we have a little bit um, higher differences in the number of the aneuploid cells. But at the age about 30 years old, we have about 70% of euploid blastocysts analyzed. So if you're analyzing them at the stage of blastocyst, it will be about 70% of euploid cells.
And excellent. Thank you so much for clarification. And next question is, so what is the percentage of mistake of the PGT-A?
Uh, okay, it was really well clarified for fish, and for fish analysis, it was about 5% of just mistakes, which came from the peculiarities of this technique. But now, when we are talking about NGS, for example, technique, uh, actually, I didn't hear any information about mistake. Just in case if it would be some kind of confusing of something, but if in the particular clinic, if you have really strong control of the for the really strong control for the um, identification of the material, so you would exclude these mistakes. And and if there wouldn't be any kind of contamination, the for this RHGH or for NGS technique, the mistake itself is not is not occur usually. But there also could be another thing that sometimes, in quite a rare case, we can obtain we cannot obtain any result, and we calculated that. Of course, it depends on the on the time from the biopsy to the to the analysis, and it depends on the and on the quality of embryo, and sometimes we have some it is possible that we wouldn't have any results, and some clinics refer that they have about 1% of such situations, but we must say that in our clinic this is about 0.1, maybe even less, but it happens. Sometimes it is something inside inside embryo that uh, we would have all the DNA damaged before you will start analysis. It means that this embryo looks well, but it is already almost died. It just faded. Just and in this case, we would have these results with no results. But as I said, in our clinic, in our practice, we have this thing really rare. But I know that in some papers it was referred as up to 1%.
Understood perfectly. Thank you so much for that. And well, let me have a look. Yes, there are like two questions. So let me show you this one. Is 7 out of 10 euploid embryos a good result from a 22-year-old donor with good quality sperm?
At 22 years old, I think it wouldn't be so, because, as I said, it was shown that at 22 year, the difference between the difference between the number of perfect oocytes a little bit different. So at the 30 years old donor, it would be 7 of 10 euploid blastocysts, 7 of 10 high quality blastocyst. But if we are talking about 22 years old donor, it could be absolutely different. And this difference is really high. And there are some explanation that at this age, the hormone system of young woman of 22 years is not so perfectly balanced. So that's why sometimes you would have, or you could obtain three, sometimes even three euploid cells up to embryos up to 10 for such uh, age.
All right, excellent. Thank you so much again for that. And there is one more question. So I believe it is our last one. However, if you have any left, this is your final call for those to type those in. So go ahead and do it. And now let's have a look. What percentage do healthy young women donors have to have embryos with trisomy problems?
As I said, about 30% of healthy young donor will about 30% of embryos will be with different chromosomal abnormalities.
Okay,
And
thank you.
actually, it is published and it is well known. That's why it's one of the reasons why we would recommend for those who is not so young as donors and they don't want experience miscarriage. But if you are starting donor program to to apply PGT-A, just not to have this experience, because you should remember that it is somewhere in the nature of human embryo development. And actually, these mistakes is not something unusual for mammalians in general. So it gives us quite great advantages to survive even if some cell dies. So it gives us really a good higher possibility for surviving. But this is the other side of these advantages, as we know that for all advantages we should pay something, and this is just a disadvantages that the other side of those advantages. So we have higher possibility for surviving, but from the other side, we have about 30, even at the young age, we have about 30 embryos with chromosomal rearrangement mistakes.
All right, excellent. Thank you so much once again for clarification. Okay. Next, there are two more questions that have just popped out here. So, what percentage of members would you expect to be unemployed at age 42?
Actually, it will depend on different things, and it will depend on the number of embryos which would be obtained for this particular person. So, if you would, and it was calculated that it would, if you would have about 8 or 9 cells, you would definitely have at least one euploid. But this, I must say, this is definitely, but actually it is something average. So it's just average thing where a lot of people of this age was calculated and mixed together, and it was found that for this age it was like this. But we, of course, we have experience when there was just one cell from a woman of 42 and it was euploid, and after analysis it will implant and perfectly gives pregnancy and baby. So it is really depends on the personal situation and personal condition, and some personal genetic background as well. And of course, in general, the risk to have aneuploidy will higher, but it doesn't mean that it wouldn't be possible.
All right, excellent. Thank you so much once more for explaining that. And now again, we have one more question that is, I believe, our last ones. Is it possible to discover mitochondrial pathway with this technique? I am asking
Okay,
because my
really
son is
good.
suffering from
Yes,
Leigh syndrome.
yes, yes. Really, really a difficult problem because it everything that mitochondrial involved from mitochondrial will will give some additional problems because of the copy number of this DNA from mitochondria. And unfortunately, we still are not ready to say that we can help absolutely in this situation. But I must say that right now, some labs in the world works on this problem, and it would be on transfer, and it will be technique based on the nuclear transfer from all sides to from all side from the healthy person without any mitochondrial mistakes, mitochondrial genome mistakes, and then transfer the uh, nucleus from the mother. And right now, the problem is that we can't transfer them without picking up at least some copies of mitochondrial genome from the mother's oocyte. And I know that some labs develop special system based on CRISPR-Cas um, background, just to avoid of this contamination with um, suffered with broken mitochondrial DNA. But right now, it's all about experimental things. So, so of course, we need to wait a little bit, and I'm sure that one day we would help those women with mitochondrial disease. And what about the son of this woman? As can see that this woman has a son, and if this syndrome in her son is not really severe, so it is in a kind of mild condition, it is possible that he will grow up and mitochondrial disease is really rare transfer from the sperm. There are some cases of transfer of mitochondrial diseases from the sperm, but it's really really rare. I don't remember the particular uh, number, but it's really rare when this sperm mitochondrial DNA can cause the disease in uh, child, just because the number of genome is incomparably different. So in all sites we have more than a thousand these copies of this mitochondrial DNA, and just some copies in sperm and there are also special mechanism of marking this sperm mitochondrial DNA just to get rid of this of them. And so for transfer from father's side, it's really a rare thing. So I would I would say that if this boy will be able to survive up to the age when he will able to have children, that then his children wouldn't have this disease.
And again, thank you so much for answering that interesting indeed question. Okay, and actually there is a follow-up from the patient. Okay, so I just want you to have a look at it. It is severe? He can't eat, speak, or walk. But thank you for your kind answer. I heard about the CRISPR technique. The disease is rare, true, but it happened to me. Just a remark, of course, but thank you.
Yes, it's really a difficult situation, I know, but I must say that some labs in the world worked hard on solving this problem.
All right. Thank you so much for your question and for sharing your story as well. Yes. And well, I'm just looking if we're having any. Yeah, there is one more question left right here. So, does IVF in itself increases the chances of unemployed embryos?
There was some analysis about this, and the most interesting, I must say, that was made by Joris Vermeersch from Belgium. He tried to compare the number of aneuploid cells after stimulation for IVF, and as a model organism, he used cows, cattle, and he found that it is not a really big difference between the IVF and stimulated and non-stimulated embryos. And then there was a really interesting analysis in Europe when they asked people to. I must say it sounds crazy, but people did it. They washed out embryos after natural fertilization and analyzed them, and they found that they again have the same number of chromosomal uh, mistakes, and we know about it because we have also a lot of number, quite a big number of first trimester miscarriages during natural conception. So it is not just consequences of a kind of stimulation. It is a matter of human embryos and mammalian embryos development. So of course, the situation is a little bit different in Drosophila, but but unfortunately we are mammals, so we have these problems common for all mammals.
All right, perfect. Thank you so much once again for your questions as well as your answers. Lots of details you have provided today. So thank you so much for joining. We will be finishing, of course. So also, is there anything you would like to add?
Um, just just again about the topic of uh, our discussion, that we know that PGT-A really helps to reduce number of miscarriages during first trimester, and this is really important to improve the IVF. And if we could do something to uh, choose those embryo which have a little bit high potential, I think that we can try to do it.
Perfect. Once again, thank you so much. And well, I just want you to see that there is one at least. Yes, thank you, Doctor. Great explanation. This clarification will be really helpful to me. This is, of course, in regards to your answer to the question. So thank you so much once again, everyone. Thank you for joining. You know, this is not an easy topic for sure, but also you have definitely explained lots of useful. We provided lots of useful details. So as you can see, there are more patients that are thankful that you've been able to join us tonight. And well, in such case, thank you once again. Have a lovely evening as well as weekend. And to all of you, I would like to invite you for our next event, which will start at 8 p.m. UK time. As you know, we have another topic to discuss. So hope you can join us as well. Even though it's a Friday, you can still ask your questions to the next doctor that we will have. And so thank you once again. and remember that it has been recorded, so you will be able to simply watch this again. And if you would like to get in touch with Asu and her team, of course, you will be able to do so. The link will be sent to you after this webinar is over, but also I encourage everyone to simply subscribe to our YouTube channel. That way you will be notified when the new video will be uploaded. Sorry about that. And of course, you can also find us on our Facebook or Instagram. That way you will be updated about all of our events. Next week we will have 10 more events, so stay tuned. And well, have a lovely evening everyone as well, wherever you are. Also, once again, thank you so much.
Okay.
Enjoy
Thank
your
you.
evening as
Thank you.
well and
Yes.
weekend. And well,
Bye. Bye.
thank you. Bye.